So my name is Jennifer Horney. I'm a professor of epidemiology at the University of Delaware and a member of the core faculty of the university's Disaster Research Center. I want to thank everyone today for joining us and set the stage a bit by letting you know that last summer, a group of us with experience in both applied and academic public health recognized the need to capture the impact of the response to the COVID-19 pandemic on the public health workforce. And our first step in this was the development of this survey, which many of you participated in. Subsequently, we have received funding for follow-up key informant interviews with a subset of respondents and initiated planning for a longitudinal study. So we want to thank you again for your engagement today. And most importantly, for your service in public health during this unprecedented time. And with that, I'll hand it over to my colleague, Christina, to hear more about the data.
Thank you, Jen. Good afternoon to everybody that is Central and Eastern time zones, and good morning to everyone else. My name is Christina Kinsiger. I am an assistant professor at the University of Tennessee, and this morning or this afternoon, depending on where you are, we will be talking about the effects of the COVID-19 response on public health. And we will be looking at this from the aspects of, mental and physical health, burnout, as well as essential functions, or in other words, the jobs that are not being done during this response. So as Jennifer mentioned, this is a collaboration among the people listed here. We also have several doctoral students who have been involved in this study to date, which we could not have done without their involvement, of course. And as Jen said, we have all either spent significant time in public health practice or have worked on a regular basis with public health practitioners in responding to disasters. So this collaboration stemmed out of our desire to help support public health practice during this unprecedented response. So the objectives of our study were to assess the effects of the COVID-19 response on our public health workforce, assessing different aspects of this response. So the mental and physical health of the workers, risk and protective factors for burnout among public health practitioners, how this prolonged response is affecting short and long-term career decisions, as well as the essential functions and tasks that are being put on hold for this response. And the study was approved by the University of Delaware IRB. And this word cloud here represents the positions of the people who have responded to the survey so far. So like Jen mentioned, we had some early discussions about some of the mental health challenges that many of our colleagues in public health practice were facing during this pandemic response. And all we had seen so far in the literature and in the news was related to the frontline healthcare workers and their experiences with this response. So we identified this need for internal occupational assessment of public health, and to hopefully call attention to what is being experienced by public health workers, as well as to potentially identify some best practices for improving the response experience. So just, a quick background. For frontline healthcare workers, COVID-19 and other similar pandemic responses have had substantial impacts on mental and physical health. We've seen many studies to date that have shown that healthcare workers are at an increased risk for developing mental health conditions such as psychological distress, insomnia, anxiety, depression, symptoms of PTSD, as well as burnout during pandemics, and even experiencing these same conditions 1 to 2 years after the event. So for example, healthcare workers during the SARS outbreak in Canada reported continued high levels of burnout up to 2 years later. And this is important because we know that mental and physical health effects on frontline workers have the potential to diminish the size of the workforce due to that burnout. And so we felt like this prolonged response has the potential to have similar effects on the public health workforce as it does on frontline healthcare workers. So as many of us know, since we have worked in or are working in public health practice, prior to this pandemic, the public health workforce was already functioning at reduced capacity due to budget reductions, layoffs, things that have been occurring since at least 2008. And we also have been experiencing an exodus of experienced workers, either due to the aging workforce or pending retirement. And I'm sure we all know public health has consistently been underfunded and understaffed, and that greatly affects our ability to perform not only our regular surveillance and public health activities, but also those same activities in the midst of any type of response. So these existing workforce and funding challenges, along with the stress and burnout associated with prolonged pandemic responses like this, are going to have long-lasting effects on public health practice. And so, as Jen mentioned, this is a study in multiple parts. So the first part of this study was a cross-sectional survey of public health professionals. And that survey is actually still open, and many of you likely participated in it. It included 45 questions across different themes like background characteristics, professional experience, mental and physical health, career trajectories, things like that. And we included a sampling frame among our professional networks, basically. So we included, the APHA Epi listserv. We sent it to some of our CSTE work groups. We sent it to professional colleagues, professional networks, as well as social media groups that had been vetted for public health degrees. And that survey is still ongoing, but I also wanted to share some other parts of this ongoing work that we're doing. So we just completed a set of key informant interviews of selected participants from the cross-sectional survey to really focus in on some of the more important concepts. And those data we have completed the data collection, and we are in the process of analyzing it. And then we are getting ready to launch a longitudinal study. So that is in protocol development and will be going through IRB review very soon. And so to date, for the cross-sectional survey, we have almost 400 responses. However, the responses that the results I'm going to present here represent responses from earlier time points, so not quite 400. So for the first set of analyses that we did, we looked at the mental and physical health of public health workforce members. And so this represents survey responses from August 23rd through September 11th. It included 225 public health workers from 31 states in the District of Columbia. It was heavily represented among our Western colleagues, and about 80% of the respondents indicated that they were part of public health practice, with the other ones coming from academia or nonprofits or for-profit type organizations. Also want to say that roughly about 15% of respondents indicated that they were from local health departments, with the rest being from about 45% from state health departments, about 20% or so from federal, and then the rest for these nonprofit organizations or these other organizations. You can see from the demographic breakdown that our survey respondents were not quite representative of what the public health workforce looks like in general. We had about 85% female respondents during this first round of analyses. A little over 3/4 were white, non-Hispanic, and 60% were under the age of 40. So like I mentioned, this first set of results that I'm going to talk about are related to the mental and physical health of the workforce. So our personal well-being section included physical and mental health status, assessing generalized anxiety disorder using the GAD-7, depression, and physical and mental health days. So our depression came from the PHQ-2, and then some other mental and physical health days question from BRFSS 2019 questions. So this represents the results from our well-being questions from the BRFSS so basically over the past 30 days, how many respondents reported poor physical or mental health days, and how many reported that those poor mental or physical health days kept them from their activities. So the proportion of respondents reporting poor health at least 14 out of the 30 days, the 30 previous days before the survey, were 13.6 for physical health, reporting a mean of 5 days, 41% for poor mental health days, reporting a mean of 12.4 days. So in general, males reported more poor mental health days, and females reported more poor physical health days. 40 to 49-year-olds were also more likely to report both more poor physical and mental health days. African Americans reported more poor physical health, but the least poor mental health days, and there were few differences noted by any of the other characteristics that we assessed in our cross-sectional survey. So this figure just shows how our respondents compared to the general population. So as you can see, our poor physical health days among the public health workforce respondents were very similar to the poor physical health days among the general population, but there was a large difference in poor mental health days among our respondents. So 41.4% compared to about 14% in the general population. Next, using the GAD-7 and the PHQ-2, we looked at anxiety and depression. So among all respondents, 41% reported some symptoms of an anxiety disorder and 29% reported some for depressive disorders. Combined, that was almost 46%. Males were more likely to report anxiety and depressive disorders. Those who were 50 years or older actually showed less likelihood to report both depressive or anxiety disorders. There were very few differences noted by race or ethnicity. Larger household sizes actually reported a lower likelihood of either of these disorders as well. And this graph shows us the comparison between our population of public health workers in the dark purple here compared to healthcare workers from other studies in the general population. And you can see public health workers reported a higher prevalence of anxiety-related symptoms, 41% compared to 26% in the general population, as well as a higher prevalence of depressive symptoms, 29% compared to 24% in the general population. The next thing we did was we assessed burnout among our respondents. So we used a non-proprietary single item burnout measure to estimate self-reported burnout. And we categorized it as both some level of burnout, so 3 or more symptoms of burnout, and then also we categorized it as high level of burnout, so 4 or 5 symptoms compared to the other. So the results of this are shown here. So I would like to highlight this at the bottom here. Over 66% of our respondents reported some level of burnout. So that means 3 or more symptoms of burnout. And then looking at the symptoms of burnout by different characteristics, we see that females reported a higher prevalence of burnout. Our oldest age group reported a lower prevalence, 65 and over had only 17% reported some symptoms of burnout compared to 57% in the 50 to 64 age group. African Americans again reported the lowest prevalence of burnout compared to other race and ethnic groups. People who were married or partnered or never married reported higher symptoms of burnout than other relationship statuses. Household size again was protective against burnout. And then experience, so the people that had joined the public health workforce within the past year reported fewer symptoms of burnout than those of us who had been in the public health workforce for 1 or more years. Additionally, academics and practitioners were more likely to report symptoms of burnout than people in other areas, so clinical, not-for-profit, and for-profit organizations. And then education was also associated with symptoms of burnout. So then we assessed both some burnout, so what were our risks or protective factors using logistic regression analyses. So again, among the people that reported some burnout, 66% years of experience was associated with higher levels of burnout, so 1 to 4 and 5 to 9 versus those with less than 1 year of experience. And then academia versus practice was also considered a risk factor. And then among those with higher levels of burnout, so again, that's 4 or 5 symptoms of burnout, age and years of experience were associated with that. So just in brainstorming and looking at some of our other data points, we noted some possible reasons for burnout among the public health workforce. So in general, almost 30%, so 26% reported an increase in the content expertise areas and the programmatic roles that they were being asked to cover mid-pandemic compared to pre-pandemic. So basically content expertise areas, so, like infectious disease, chronic disease, environmental health, et cetera, those areas increased from 1.7 areas per person pre-pandemic to 2.0 per person mid-pandemic. And then our programmatic roles, so administrative roles, evaluation, surveillance, things like that, those increased from 1.8 pre-pandemic to 2.3. Another important change pre to during the pandemic, the number of hours and days worked per week increased drastically. So those people who reported 5 days, more than 5 days of work per week increased from 7% pre-pandemic to 62% during the pandemic, and that was an average of 5.9 days worked. And then those who reported working over 40 hours per week increased from 21% to 68%, with an average of 50 hours per week being reported among respondents. So then I wanted to talk about career plans and how this has been impacted during the prolonged pandemic response. So we basically asked participants to share what their career plans were, what they thought their plans were January 2020 compared to when they took this survey, from August to current, to estimate career trajectories as a result of this response. And here you can see that this response has changed the career trajectory. So there, among those who said that they were going to leave or retire this year, pre-pandemic percentage is in the magenta color, and then the mid-pandemic is more of the lavender color there. So you can see that increased from 1 to 5%. People who said that they were going to stay in public health practice but potentially leave in 1 to 2 years increased from 5 to 12%. And then the people who said that they were going to stay for 3 or more years in public health decreased, actually. So 85% of people said that they were going to stay for 3 or more years pre-pandemic versus 62% when they responded to this survey. And then the undecided increased from 9 to 22%. So you can see that this is going to have a potential long-term impact on our public health workforce. So then we asked questions related to what were the gaps in the workforce and the public health functions as a result of this pandemic response? So what is not being done? And so this was a second set of analyses that represents survey responses from August 23rd through October 5th. Almost 300 public health workers were included in this particular analysis. Of these, we considered 16 or 5% were new hires since the pandemic started. We had an even greater proportion of respondents from Western states when we did the analysis the second time, and more public health practitioners than the other groups were included. Similar demographic characteristics distribution, but I also wanted to add that over half of our respondents had between 1 and 9 years of experience, and almost 40% had 10 or more years. So the people who responded to this survey tended to be, more experienced in public health. So among our respondents who had worked in public health prior to the start of the pandemic, so this includes 282 of the respondents that were pre-pandemic public health workers. Among those, 60% reported having no changes in the number of content expertise areas or programmatic functions. But as previously mentioned, we did have 26% reporting an increase in both program changes or content expertise changes and role changes, and just about 10 or 11% reporting actual decreases. So maybe they had 2 or 3 program areas that they were responsible for pre-pandemic, but that decreased during the pandemic to be more narrow in scope. So then the types of program or content expertise areas that are covered pre versus current or mid-pandemic, we found that many essential public health content expertise areas have had staffing removed in order to respond to the COVID-19 pandemic. So compared to pre-pandemic, the following program areas saw significant decreases in staffing among those surveyed from August through October of 2020 compared to January 2020. So we saw about a 40% decrease in chronic diseases, about 42% decrease in maternal child health and substance abuse, saw about a 30% decrease, environmental health, injury, and other program areas. And those other program areas included things like HIV, sexually transmitted infections, social epidemiology and health disparities programs were among those. So we've seen some significant declines in the workforce in areas of particular importance in our country. And on average, the total number of functions or roles increased from 509 total to 607, or 1.7 to 2.0 areas per person. And then the types of programmatic functions covered, so the roles that people played pre versus current or mid-pandemic. So the total number of functions or roles increased, like I said previously, from 536 to 697. So in general, even though some people did see a decrease in roles, overall, most people saw an increase. And so where we saw these changes, surveillance, program manager, planning and preparedness, administration, and policy roles actually did not change pre-pandemic to mid-pandemic. But the places where we saw a significant decline were program evaluation, which saw a 36% decline in people filling program evaluation roles, and health education, which was 27%. We also actually noted a significant increase for disease investigation, a 35% increase. So we also asked an open-ended question on our survey. So the question was, during the response to COVID-19, what routine duties or services have or are not able to be done? Or in other words, what pre-pandemic public health services are not getting done now? So across the board, we noted some themes. So investigations related to other communicable and non-communicable diseases, and specific ones that were mentioned were sexually transmitted infections, enterics, blood lead, vector-borne immunizations, things like that. Other routine disease surveillance and evaluations of surveillance programs were also noted as not being done. Another important theme was the closure of public health facilities in response to the pandemic, which limited individuals' availability for walk-in programs for addiction. It limited stakeholder collaborations as well as maternal child health programming. And then another theme that emerged from this question included grant-funded work. So people that had specific jobs or activities that were required for grant funding were put on hold for this response, such as the opioid abuse prevention programs. So this slide shows where COVID-19 response staff are being pulled from. So among the people that reported working on COVID-19 during the pandemic, 47% came from infectious disease program areas, and 56% had surveillance roles pre-pandemic. So those are the most obvious places where we would pull individuals from working for a pandemic response such as this. But also we noted that chronic disease, substance abuse, and other areas where individuals were being pulled from those, especially on the programmatic functions or roles. We saw a loss in evaluation, and then DIS were being pulled as well into the COVID response. And so this shows where workforce was being maintained during the pandemic. So the way this is set up, so infectious disease programs maintained 49% of their pre-pandemic workers. So people that said that they were infectious disease prior to the pandemic starting compared to what they were reporting during the pandemic, 49% reported that content expertise area at the same time point. So these lower rows in the table represent places that lost a good proportion of their pre-pandemic workers. So chronic disease, injury, environmental health, MCH, vital stats. Across the board, these places lost a good portion, so 80% of their workers in chronic disease compared to 67% in MCH. And then among programmatic functions and roles, we see that surveillance maintained their pre-pandemic workers, program managers mostly maintained their pre-pandemic workers. The places where we lost our workforce included administration, evaluation, DIS, planning preparedness, and health education. So we also asked our colleagues that completed this survey, what were some best practices that they were experiencing in the workplace to help them do their job? So basically the question was, are there any best practices observed in the workplace that you'd like to highlight? And please be specific as possible. So there were 3 themes that emerged from this question. Related to online communication, mental health support, and food or lunches for in-person workers. So for online communication, people mentioned things such as having group chats, using Zoom and Skype for communication were important, Microsoft and WebEx Teams, and then Google and Office 365 for document sharing. People mentioned things like, this allowed for interaction, social interaction, as well as collaboration. For mental health support, people mentioned that some of their workplaces were providing check-ins with counselors or mental health first aid sessions to help their workers get the support they needed. Some were offering no-cost services for some of these mental health activities, and some were also actually providing financial support for counseling and other supports like childcare. And then finally, many mentioned that their places of employment were offering meals or beverages or healthy food options to those people who had to be in the emergency operations centers or were required to come to work in person. So right now, I would like to open us up for some questions. If you would please introduce yourself in the chat and type in your question, and then we will see how we can answer these questions. don't seem to be any questions so far in the chat. Great, we have some coming in now. Thank you.
Hey, Christina, this is Taylor. We have some questions coming out. I think you can see them all, but the first is from Hope. She says, how long was your survey and how long did it take people to complete it? Do you have that answer?
Yes, so there were about 45 questions on it, a few of which were open-ended, but most of them were multiple choice or, short answer. So I believe that we timed that roughly to be 30 minutes or less. Kayla, is that correct?
I believe that was right. It was somewhere plus or minus 5, around 30, so about 30 minutes. I got a question from Dave Zane in Austin, Austin Public Health. He says, hey Dave. He says, did we look at whether respondents were from local versus state health departments?
So yes, we did. That was an optional question where they could identify their agency. And so for those who identified their agency, we were able to see whether it was roughly 10 to 15% were local. I think I figured that about 40% were state, and then the rest were like federal, nonprofit. Maybe there was closer to 50% that were state, sorry. But I think for the longitudinal survey, we've already talked about having a question specifically for that so that people don't have to identify their agencies, but can identify which level of service they are.
Okay, next question from Mona from CDC. Hi, Mona. Can you tell us how you gathered info on employee roles?
This is Meredith. I don't mind taking this one.
Perfect.
Go for it.
So Mona, we had a multi-response option pick list for roles that included things like administration, evaluation, program management, and there was also an other please specify. So you could pick as many of those that you had experience with in general, and then we were asking pre-pandemic and post-pandemic. So there were actually several questions about roles that we used to factor in how people's roles had changed.
Thank you, Meredith.
Okay, another question from Anna at CDC. Can you explain why being Black was a protective factor against burnout? If you can, if we can answer that question.
Well, that's a very good question. And I will say that in the logistic regression analysis, we did not find that to be a significant protective factor. It was just that there was a lower prevalence of Blacks that were reporting symptoms of burnout. But I will also say that that was a very small sample size. Remember that analysis, I think, was based on 75% was identifying as white, non-Hispanic. So the rest of our sample was divided amongst the other race ethnic groups. So we did have a small sample size of minorities. And so we are hoping with our longitudinal survey, we can get a better representative sample as well as address some of these issues with our next set of analyses.
Okay, I have another question for discussion. This is, do you think the COVID response is unique in terms of burden compared with other natural hazards and disasters? So do you think the COVID response is unique in terms of the burden compared to disasters, natural hazards and disasters?
Jen, would you like to take this one?
Sure. So, I mean, I think that typically when we have other types of events, we have a more limited geographic or time scale. And what will be interesting and valuable about looking at this over time is to see, have people felt some relief with the approval and implementation of the vaccination campaigns that maybe mitigated some of the feelings of burnout, or was the job of needing to stand up a vaccination campaign after, nearly 9 months of long days and long weeks, responding just, one more thing that is pushing more and more people to decide that public health is not the career for them. So I think that, again, like you mentioned earlier, is another reason to think about this longitudinally. And I think even if we look back at the H1N1 response, although it was many months long, it was not as severe and extensive as this response has been. So really unique from the type of public health emergency response responsibilities that public health agencies usually have in a more typical type of emergency response.
Great, thanks. Here's another question, Christina. As we enter vaccinations, do you anticipate that the burnout is increasing with the added responsibilities?
I imagine that is definitely going to be the case. I mean, that is an extra layer of response. You're still doing, contact tracing in many places. You're still doing the testing. You're still doing regular surveillance. And now we've added vaccine distribution and monitoring of that as well. So I do think that this is going to potentially show an increase in our levels of burnout.
Okay. Got another question. This is to anybody. Were there any trends when burnout, anxiety, and depression were stratified by state? I think you could answer that one pretty easily. I asked because governors lead, how they lead during the pandemic may influence mental health. Did we do any of that stratification by states?
So we have not done that. Z, thank you for your question. We did collect that information about states, where they were from, and we had a very large representation of survey respondents from the western part of the country. And so because we had such a small sample size in states in general, we did not do any sort of stratification that way. We might consider doing a regional stratification, like, South versus Northeast versus West, because they're in Central, because there tends to be, sort of like similarities in the way that governors have responded by region. Not always, but often. So that might be a next set of analyses. So thank you for that suggestion.
Got another question from Hope CDC. Okay, this is a great question. In retrospect, what do you wish you had asked the participants, and what information did you collect that wasn't useful? Anything that comes to mind from anybody on the team?
Does anybody have anything? I mean, I definitely think that some of our questions, like what areas did you have any experience in, were just, too broad to really do anything with. And some of our open-ended questions, like, agency, we had to extrapolate from our information. So I think we're going to make that, more specific options in the future. Kaylor, Meredith, anybody have any? We kind of wanted to ask more about, some of the political pressures that have been faced by our public health colleagues, and we are planning on doing that in the longitudinal survey.
Yeah, I would say as far as anything that we asked that maybe wasn't useful, there was very little of that. I think we trimmed it down pretty well from what we originally started with, and almost every data point we've used for some type of analysis to date. So not a whole lot of waste, I would say, with this survey.
The one thing I will note is that the burnout measure we used was a single item non-proprietary scale, and it it is not the same burnout measure that was used in other COVID healthcare worker surveys or SARS healthcare worker studies, but the one that was commonly used cost a lot of money, and so we were limited on that. So we didn't use the same measure as other studies have done, but we still are able to measure burnout.
Okay, I have another question from Deb. Any key takeaways? I think kind of summing this up, basically any identified gaps, action items off of these results.
Christina, can I take that one?
Absolutely.
So I think one of the most, the biggest gaps, and we've seen this in some other work that we've tried to do to characterize what public health actually does when there is any kind of emergency, not only a pandemic. But I think that there has been a lot of understanding on the burden that frontline healthcare workers have faced in responding to the pandemic. And because public health is typically invisible when we do our job well, when there's not outbreaks of childhood diseases, nobody says, great, we got all those vaccines. We just, think that that's an invisible achievement. Or when you don't get sick when you go to a restaurant, we don't think that's because the environmental health people were there inspecting it. And so I think one of the challenges has been sort of finding a place for this in having people, needing to educate people that public health agencies and workers are responders during this time, and that this is more than kind of an occupational health piece, because I just think that people have a gap in understanding the role that public health agencies and the public health workforce plays in the community in general, and then more specifically in during any type of emergency.
Thanks, Jen. Another question. This is from Susan with the World Health Organization. She makes some great points that we can take down, I think, for our work moving forward. But she has a great question here, talking about some of the different pressures that might lead to some of these mental health outcomes or burnout in our workforce. But she does ask a good question. She says, do we know of any other studies like this that are happening in other countries? Are we aware of that?
I am not.
Yeah, I am not.
In looking really, really hard, I only found one study that I believe was in the Netherlands looking at public health burnout after H1N1. Again, I think there's a lot looking at different sectors maybe, but very little that directly addresses the public health workforce and the role that they play.
Christina, did we ask information about whether staff or these employees, those that filled out the survey, were working at home versus in office? And then did they have kids? And were they attending school virtually or not?
So we did ask about how many people currently reside in your household by age, but we did not ask about working at home specifically versus in the office, or whether staff had children, attending school virtually. So I think that those will be things that we want to consider for the longitudinal survey. Thank you.
Mm-hmm.
So we did ask about sources of support in terms of if people were getting support for things like childcare or online learning. And so we could, I think, look at that. And then in the open-ended question, we actually heard a lot from people about the idea that, as their departments were able to adapt to the pandemic and get them set up with the IT needed to work at home, in many cases, people said that it was actually isolating. And if they were going to be working all these hours and be under all this stress, at least they had this camaraderie of being in the office with each other. And so that was definitely a theme in one of the open-ended questions. Certainly, you know, the ability to work at home would be a benefit for some with different responsibilities.
And it looks like we got one more question on here. This is from Barbara at CDC. We know the name of the single item question for burnout.
Taylor, do you know that one?
I don't remember the name of it. I feel like they titled it in the paper non-proprietary single item burnout question, honestly. So I don't know the name of that specifically.
Well, let me share our contact information on the screen really quick. And Barbara, you can email us and we can send you that information. So that is next slide. Maybe. There we go. So yes, if you want to email us. And then for the other person from CDC, is it Mona that said that she wanted to talk to us? Please reach out to us. We would love to talk to you about your study.
That's all the questions I've received privately or publicly.
Well, then I will end it with, if you're interested in signing up for our longitudinal study, please sign up at this tiny URL listed here. I believe Kayla put it in the chat earlier in the conversation. So you can click on that link and provide us with your contact information, and we will be contacting you as soon as we get this study off the ground.
There was a question, sorry, Christine,
so
there was a question regarding the slides.
Okay.
Are we going to be sharing the slides or maybe just the recording, or do we know what we're doing there?
Yes, so we did record this and we will be sharing it. So for anybody who registered for the studies, or sorry, for this presentation, I will be sending that that link out, and then please feel free to share that with your networks as well.
Great. Okay, that's all I have. Thanks, Christina.
Well, thank you everybody for joining us today. We appreciate your feedback and your input.